Welcome to the deep dive. If you follow emergency medicine or critical care, you know that moment the heart stops. A cardiac arrest it's one of the most terrifying events a person can experience.
Absolutely.
But the hard truth is, achieving a return of spontaneous circulation, or ROSC, where the heart beats again, that's really only the beginning of the fight.
It's the highest hurdle for sure, but maybe not the most devastating one.
Yeah.
While survival rates have thankfully been, improving over the last couple of decades, the neurological outcome for those survivors remains a massive, life-altering problem.
We're talking about post-cardiac arrest brain injury, or PCABI. It sounds clinical, but the reality is it's profound. The majority of people who survive the arrest are afflicted by some degree of cognitive dysfunction.
And this isn't just, slight brain fog. PCABI is the primary factor leading to death in a staggering 68% of patients who initially get ROSC from an out-of-hospital cardiac arrest.
Yeah.
And for the patients who do survive long-term, their lives and the lives of their families are completely restructured. They face major cognitive impairments, issues with memory, executive function.
And the healthcare costs associated with years of rehabilitation and support must be just astronomical.
They are. It truly is the defining crisis of post-resuscitation care.
For years, the standard approach to try and mitigate this brain damage has been targeted temperature management, or TTM. This meant actively cooling comatose patients down to around 33 degrees Celsius, essentially putting the brain on ice.
Right. That PTM standard was established way back in 2002,
Yeah.
and it provided a real foundation for care. But the science evolves, and in recent years, some large, well-designed trials, specifically those in 2013 and 2021, they really challenged that dogma.
How so?
They found that there was no significant difference in neurological outcomes between actively cooling patients to 33 degrees Celsius and simply aiming for a controlled normal body temperature, or normothermia.
Okay, that is a massive shift in standard practice. We went from you absolutely must cool the brain to essentially just don't let the patient get a fever.
Precisely. The latest consensus suggests the genuine benefit of TTM was never in the induction of hypothermia itself, but rather the strict avoidance of hyperthermia.
Fever kills brain cells.
It does. So if we strip away the supposed benefit of active cooling, we're sort of left without a reliable, proactive, neuroprotective strategy.
And that sets the stage for our deep dive today. Given this massive therapeutic gap, researchers have been urgently looking for alternative interventions. We examined a recent review that focused on a common, readily available, decades-old emergency room drug, ketamine.
Okay.
Can this drug, which we currently use for sedation, actually be repurposed as a powerful neuroprotective agent to shield the brain after cardiac arrest?
It's a compelling question because if the answer is yes, it changes everything about initial care.
Okay, let's unpack this. Starting with exactly what happens to the brain during a cardiac arrest that causes such massive widespread damage.
Yeah, we need to understand the underlying pathology, which clinicians model as the two-hit mechanism of post-cardiac arrest brain injury.
Two-hit, okay.
The brain is uniquely vulnerable because, despite being only about 2% of your body mass, the cerebrum demands between 15 and 20% of your body's total cardiac output and 20% of its oxygen, just to run the baseline processes.
That's an extremely high overhead.
Exactly. So when the heart stops and blood flow disappears, that immediate lack of oxygen causes the primary ischemia. That's the first hit.
And the core machinery of the neuron fails almost instantly.
Instantly. And what does that failure look like at the cellular level? It's largely driven by a process called excitotoxicity.
Excitotoxicity.
Yeah, our neuronal function relies on maintaining these steep chemical gradients across cell membranes, managed by power-hungry systems like the sodium-potassium pump. When oxygen is cut off, the pump stops running.
The power shuts down.
Correct. The chemical gradients collapse. And this initiates a cascade that leads to a massive toxic increase in intracellular calcium within the neurons.
Okay.
This calcium surge forces the uncontrolled release of glutamate from vesicles. And glutamate, as you know, is the major excitatory neurotransmitter.
So the cells are essentially being overwhelmed and chemically attacked by their own primary signaling molecule. It's like a short circuit causes the brain to flood itself with its own fuel, but it's toxic now.
That is the perfect analogy. And if the first hit were the end of it, the damage would be bad enough. But the second hit, the reperfusion injury, that happens upon ROSC when the heart restarts and oxygen returns.
Which seems so counterintuitive. Oxygen returns, the problem should be getting fixed, right?
Not at all. We are restoring flow to tissues that are already critically injured and adapted to a state of near death. The initial glutamate surge and high intracellular calcium from the first hit have already left a terrible legacy.
Which is what?
They cause the postsynaptic cells to upregulate and increase the number of their NMDA receptors.
And why does that upregulation matter so much when the blood returns?
Because NMDA receptors are highly permeable to calcium. So when blood flow returns, there is residual glutamate still floating around, and it binds to these newly amplified receptors.
Oh.
This triggers a massive second-wave surge of calcium into the postsynaptic cell. It's a vicious, terrible feedback loop that just continues the destruction.
So you're turning a localized initial injury into this self-perpetuating cycle of damage.
Yes, and this excessive calcium accumulation triggers the full-blown destructive sequence. Mass production of reactive oxygen species, activation of destructive enzymes like proteases and phospholipases, and ultimately the initiation of apoptotic cascades.
Programmed cell death.
Programmed cell death. And what's critical for clinicians to remember is that this reperfusion injury doesn't stop when the heart restarts. This programmed destruction can continue actively for up to 72 hours post-ROSC.
That explains the long-term devastation. And these apoptotic cascades, they must specifically target the most metabolically demanding areas, like the hippocampus, our memory center, and the neocortical areas.
That's right. And that directly translates to the PCABI symptoms we see: profound impairments in memory, executive functioning, and the psychiatric fallout like depression and PTSD.
So we have to stop that cycle. That excitotoxicity pathway is the critical intervention point.
It is.
And if the underlying molecular problem is this runaway glutamate and subsequent calcium surge, then the solution has to be something that intervenes right at the receptor level. Which brings us to ketamine.
Exactly. The mechanism is so beautifully targeted to this specific pathology.
How does it work?
It truly is. Ketamine works on a molecular level to be a potent anti-excitotoxic agent in a twofold manner. The first way, which is perhaps less publicized, is that it actually interferes with the presynaptic release of glutamate.
So it stops it at the source.
It reduces the ability of those glutamate-containing vesicles to actually bind to the presynaptic membrane and dump their contents into the synapse.
So it reduces the supply. That's a pretty good first line of defense.
It is. And the second, more famous action is that it acts as a non-competitive antagonist of the NMDA receptor itself. By physically lodging itself inside the channel, it prevents that damaging rush of calcium into the postsynaptic cell.
Does ketamine block every NMDA receptor in the brain equally? Because, NMDA receptors are important for normal function too, right?
That's a great question, and it's where the detail really matters. Ketamine doesn't target all NMDA receptors equally. It has a specific preference for those that contain the GLON2B subunit.
GLON2.
Yes. This subunit is particularly prominent in areas that are vulnerable to excitotoxic damage, and by targeting it, ketamine blocks the receptor and prevents that fatal calcium entry, inhibiting the very apoptotic cascades that define PCABI.
So that molecular specificity is key. It's not just a blunt instrument, it's a targeted chemical shield against the specific mechanism of reperfusion injury.
Exactly. And the logistical advantage here is huge. Ketamine is already a common tool in the emergency setting. It's used for necessary sedation during resuscitation procedures or when CA patients are admitted to the hospital.
So you could just use it then?
If we administer it then, we could potentially achieve necessary sedation and initiate neuroprotection simultaneously. It's an easy clinical adoption if the data supports it.
But, as you pointed out, there are no definitive clinical trials in cardiac arrest patients yet.
Not yet.
Which means we have to lean heavily on the preclinical findings and related studies. What did the source material show about how this mechanism translates into, tangible protection?
The animal models provide a very strong and consistent narrative. Let's start with the rat ischemia model from Church and colleagues. These researchers treated rats with ketamine both before and after the ischemic event.
Okay.
And they found significantly greater neuronal preservation compared to the non-treated controls.
And what part of the brain were they allowing at?
They focused specifically on the CA1 hippocampal pyramidal neurons. That's crucial because the hippocampus is ground zero for memory and executive function.
So if you can preserve those cells, you preserve the function that defines quality of life.
Precisely. The study showed ketamine literally preserved more memory-critical brain cells.
That's a huge step toward proving efficacy. But if we want to trust the mechanism, it needs to hold true across different biological models, right?
It does. The zebrafish CA model, for instance, showed that pretreatment with ketamine significantly decreased calcium wave propagation and neuronal apoptosis.
And the bottom line for the whole organism.
It increased the 5-day survival rates compared to controls. The mechanism held true, even in a much smaller organism.
Okay, so moving to the most translatable evidence, what did the canine model tell us? Because dogs are a much closer physiological model for human cardiac arrest.
For sure. Giuliano and colleagues used a canine model of hypothermic circulatory arrest. The dogs that received ketamine, administered both pre- and post-arrest, showed significantly lower neurobehavioral deficit scores at 24 and 48 hours.
Which means they were just functioning better post-arrest.
They were. But the real clincher is the hard data beyond just observable behavior.
The biomarkers.
Absolutely. They also measured biological markers of neuronal injury in the blood. They saw significantly lower levels of neurofilament H and neuron-specific NLAs in the ketamine group.
So think of these molecules as the chemical smoke signals of a dying brain.
That's a great way to put it. When neurons die, these proteins are released into the blood. Ketamine significantly lowered those smoke signals.
That's compelling. It shows both preserved function and reduced cellular pathology. And I found the detail about the different drug forms fascinating.
Yes, the investigation into stereoisomers. Proschel and colleagues found that S plus ketamine resulted in improved cortical oxygen saturation and reduced neuronal loss compared to the isomer.
So what this tells researchers is that when clinical trials eventually run, they shouldn't just look at the standard racemic mix. They may be able to maximize protection by using a specific form of the drug.
That's the hope.
And beyond cardiac arrest models, the evidence for ketamine's neuroprotective power is actually mirrored in related clinical conditions that involve acute brain stress, like severe epilepsy, for example.
That's highly relevant because post-anoxic electrographic seizure activity is a common and dangerous consequence of cardiac arrest.
Right.
Ketamine has been successfully used to treat severe refractory epilepsy, demonstrating its ability to rapidly dampen hyperexcitation in the brain.
And the findings in cardiac surgery patients are perhaps the most convincing clinical link. Those patients undergo massive physiological stress and often experience cognitive decline afterward.
Yes, the Hudith study showed that patients who received a ketamine bolus prior to cardiac surgery had significantly lower concentrations of C-reactive protein, a major inflammatory marker 1 day post-op.
But the most important part
is that 1 week later, these patients scored significantly higher on tests of nonverbal memory, verbal memory, and executive function compared to the placebo group.
That's a direct link to improved cognitive outcomes following acute surgical stress. It suggests ketamine doesn't just prevent damage, it mitigates inflammation and helps preserve function.
And finally, in traumatic brain injury, or TBI, ketamine has been shown to reduce spreading depolarizations.
Which are what exactly?
They're these electrical waves of energy failure that propagate through injured brain tissue, leading to the breakdown of functional neurons and ultimately poor patient outcomes.
And the fact that ketamine can suppress these destructive waves in TBI just reinforces its broad applicability as a brain protector.
It does.
So the scientific argument for efficacy is very strong. But if ketamine is so compelling, why isn't it already standard treatment post-ROSC? We have to address the major historical barrier, the fear surrounding ketamine and intracranial pressure, or ICP.
This is a classic example of old data casting a long, long shadow over modern practice. Clinicians were historically taught that any acute neurological injury, especially one with potential cerebral swelling, was a contraindication for ketamine because it supposedly drove up ICP.
Okay, so if the current consensus is that this fear is a myth, where did the initial training even come from?
It originated primarily from 6 small studies published between 1971 and 1972. They were the foundation for that dogma.
That's a long time ago.
It is. And when contemporary researchers look back, those studies were underpowered, often involved patients with pre-existing confounding issues like abnormal cerebrospinal fluid pathways, and frequently failed to account for simultaneous changes in blood pressure, which heavily influences ICP.
So we've been operating under the assumption that ketamine is harmful to the injured brain based on 50-year-old methodologically flawed data.
Exactly. The current consensus, supported by extensive systematic reviews and modern studies, is that the fear is largely unwarranted. Recent trials in critically ill patients showed ketamine did not significantly affect cerebral perfusion neurological outcomes or mortality compared to alternative sedatives.
And the evidence is actually starting to swing the other way now, isn't it?
It is. Some preclinical trials, specifically modeling elevated ICP, showed that racemic ketamine could actually decrease the elevated pressure by more than 10%. so the tide has definitively turned.
So the hurdle is cleared.
Experts now generally agree that ketamine should be considered safe for patients with normal cerebrospinal fluid flow and may even be beneficial. It clears a huge logistical hurdle for its use in post-DA care.
Okay, so assuming that hurdle is cleared, researchers need to think about future trials and who the competition is. Ketamine isn't the only NMDA antagonist out there. Who is next in line for a comparison?
The major pharmaceutical competitor for this mechanism is memantine. It's already clinically available and is another NMDA antagonist, but its mechanism subtly differs from ketamine's, which is what makes the potential rivalry fascinating.
We know ketamine preferentially targets the low N2B subunit. What about memantine?
Memantine is hypothesized to be more effective at inhibiting NMDA receptor subtypes containing the GLON2A subunit. This subunit is often found in the primary synaptic receptors in the brain.
And why does this subunit distinction create a potential scientific battleground?
Because memantine's antagonistic activity is also highly dependent on the intracellular calcium concentration. In pathological states like the massive calcium overload, we see immediately after cardiac arrest, memantine has been shown to slow the recovery from calcium-dependent desensitization in the 2A receptor.
So if memantine's action is triggered by excessive calcium, it means it potentially acts preferentially in the very regions where excitotoxicity is raging,
Making it a highly targeted intervention as well.
So this raises the critical research question.
It does. Future studies most rigorously compare the efficacy and safety profile of ketamine versus memantine and perhaps other antagonists like dextromethorphan, specifically in the cardiac arrest survivor population.
Which brings us to the overall clinical gap. Even with this strong body of, hypothesis-generating evidence, many researchers still rely on generalized stroke models to represent ischemia, overlooking the specific, unique vulnerability of the global ischemic insult experienced by the cardiac arrest patient.
And that is why we still lack the definitive clinical proof.
Yeah. We have all the pieces, but they haven't been assembled into a standard of care recommendation yet.
Not yet.
So let's bring this home for you. What we've unpacked is that the catastrophic brain injury following cardiac arrest, PCABI, is driven by the two-hit mechanism of ischemic and reperfusion excitotoxicity. Ketamine's molecular action directly counters this cellular damage, chiefly by acting as an NMDA antagonist targeting the GLON2B subunit. The preclinical evidence across complex models, rats, zebrafish, and canines shows clear, measurable neuroprotective effects.
And the historical clinical barrier, that half-century-old fear of increasing intracranial pressure, has largely been put to rest.
The science is clear that ketamine holds tremendous promise to change post-resuscitation care.
It does.
But the reality today is that the administration of ketamine in the immediate post-ROSC period is currently determined solely by the need for sedation, not by a neuroprotective protocol.
That's right.
So considering the robust preclinical evidence, the cleared logistical barrier regarding ICP, and the fact that survivors of cardiac arrest are routinely left with devastating long-term cognitive deficits, what are the ethical and logistical imperatives for immediately launching formal, large-scale clinical trial programs? We have a widely available, cheap, and effective potential solution, but without that definitive clinical proof, millions of future CA survivors will continue to suffer the consequences of PCABI. That is the question we are left with.
It's the highest stakes question in resuscitation research today.
Something to mull over until our next deep dive. Thanks for listening.